Hello, everyone. We're going to be talking today about inpatient facilities and the related departments, the hospital departments that are involved in inpatient facilities. There are several types of facilities that some people aren't aware of. And so we're going to talk about those kind of in depth and tell you about how they do reimbursement, who's able to go to a different type of facility, as well as the providers that are involved in those specific facilities. So let's get started. The objective that we're going to talk about, it doesn't look like much, right? Just 3 points, but it's pretty intense, a lot of information. So we're going to primarily understanding the different types of inpatient facilities. We're also going to talk about the departments that are involved with inpatient facilities when it is connected to reimbursement. We want to know how the facilities are reimbursed, as well as how hospital outpatient departments are set up and the reimbursements that are involved in those as well. So it doesn't look like much, but we are going to go over a lot of information today. The different types of inpatient facilities that we're going to discuss and that are out there is, number one, acute care hospitals. So this is a hospital that primarily we think of as regular hospitals. Okay, so there isn't, when somebody is acutely sick and they need care, it doesn't matter whether it's just an observation over the night stay or it's just a few days. Then most general hospitals, as we think of them as a hospital, is an acute care hospital. Then we have critical access hospitals. These are different than acute cares in that they're usually smaller and they specialize in something specific. And then we have teaching hospitals, very much like acute care hospitals, but they're partnered up with a university and their teaching providers. We have skilled nursing facilities as well as long-term care facilities. Sometimes people get those confused, so we're going to talk about those and how they are different. Starting off with acute care hospitals, what do you need to know about an acute care facility? Well, what they're going to do is, that's the general term, like I mentioned just a minute ago, that this is your mainstream hospital. They're acute care hospitals. They are not set up for long-term care. If you have something wrong with you that's going to keep you in a facility for an extended period of time, you're not going to be going to that acute care hospital. This is for acute stages of a condition. Inpatients generally have severe symptoms, sudden onset, that's where the acute comes in, and they can be serious where, if somebody has a car accident, a motorcycle accident, or a lot of times they're admitted through an ER, some type of trauma or injury, heart attack. Ooh, I got a fly going here. Sorry about that, guys. And cancer treatments, that can, not extended treatments, but, maybe having a procedure done to remove a cancer. That's what you're going to see in acute care. You have general hospitals in the acute care logo. So what they do is they take care of all types of patients. That's different when you're talking about a specialty hospital, because a specialty hospital will work with something specific, like the example they give here is psychiatric or orthopedic. They also have cardiac centers, cardiac hospitals. They have hospitals that deal with cancer exclusively, then or that they're known for cancer. So everything you need to treat for, or like psychiatric, that's all right there. Okay. Specialty hospitals. In addition, we have private hospitals and public hospitals. The difference that you'll see, you will hear the term private hospital. Usually private hospitals are going to be non-for-profit hospitals. A lot of hospitals that are religious based are going to be private hospitals, like Mercy Health, St. John's, St. Mary's. Those will be religious private hospitals. Mayo is also a private hospital, religious based. The Mayo clinics. Then we have public hospitals, and those are different in that who owns them, they are for profit. Okay, so they, not their core values are the same. They're still treating you for the same reasons as a private hospital, a public hospital will, except that their bottom line there is a lot different. It has to be met, so they are owned by governments, and they can be either local, meaning a city may own the hospital, state or federal, on a state or federal level. Again, these are public hospitals. The difference between public and private is non-for-profit and profit. Okay. When I was in Texas, we had the town that I was in. I lived in San Angelo, and they had two major hospitals, and one was Shannon, which was a non-for-profit private hospital that was started by a family. And then there was a community hospital, which, again, often hospitals that are public hospital have names like community hospital. And again, both great hospitals, but one was a private, non-for-profit, and the other one was a profit hospital or a public hospital. Both very good hospitals. Now, let's talk about hospital inpatient. What does that mean if you are dealing with inpatient in a hospital? It requires that the patient be admitted, and this is done by a physician order. All right, there's no way to be admitted into a hospital unless a physician writes out the order for an admission. That's the only way that it can be done. Now, this is all based, though, on what the provider, the physician, decides. So medical necessity is the key here. For you to be admitted, then as an inpatient, literally an order is written. It's not like a prescription, but it is. That's an order, but it's an order written down that says, I want this patient admitted. If you come in through the ER, right, you're not admitted. But let's say that they want to keep you overnight, you would be admitted into outpatient observation. Okay, you have to have an order for that. We're going to keep you overnight. We're going to see how you're going to do. And then if they say, no, we need to admit you, run more tests, make sure that you're going to be okay, the physician will write the order and state, the medical necessity is we have a pending MI, and we need to run more tests, and we also need to go in and do an angioplasty and make sure that the rest of your organs are not in jeopardy, et cetera, et cetera. Okay, so the only way to be classified as an inpatient patient is a formal admission by a physician order into the hospital based on medical necessity. When we do that, there is a special little rule that goes with Medicare. The Medicare appropriate admission requires something called a 2 midnight rule. You need to memorize this. I'm real good about telling you if it's something that needs to be memorized or not. You're going to be required to understand the 2 midnight rule. And it gets a little confusing sometimes. Now, I've always had a problem with times and dates and counting that stuff out. My brain doesn't click well with that. I don't know why. But the 2 midnight rule just basically means that this patient is going to stay in the hospital for 2 midnights. Okay. Now, this is they have like a 12-hour observation, and then when it goes like past the midnight mark, then they are required to be set up as an inpatient, things like that. But keep in mind that that you it's based on hours. It isn't necessarily based on when you're admitted. Okay, so you can be admitted at 10 o'clock in the evening, all right, and then the midnight rule, right, it that makes a difference in how many hours you're in there. But for Medicare, 2 midnights, that's what they are expected to stay, 2 midnights, 2 midnight rule. There are exceptions to this. Really, the exceptions are if you're on a Medicare inpatient only list, or if you're transferred in, or the patient passes away. Okay, that's the exceptions to the 2 midnight rule. This works with all inpatient facilities, all acute care facilities, and that includes long-term care hospitals as well as critical access hospitals. So long-term care hospitals, we're going to talk about more in depth in both of those in just a minute. So keep in mind that the 2 midnight rule, it applies to inpatient acute care facilities, and that is including the long-term care and the critical access. So what do inpatient services uh, uh, actually include? What are we talking about when we say that a person is being admitted to inpatient? What are they expected to get? Well, they're going to be able to get a place. They're going to have a bed. That doesn't mean that they will have a bed that's a private room versus a room with 2 people in it. Different facilities, not so common necessarily in the United States, but there are other places where you could be on a floor that has more than one patient in a room. Okay, so with inpatient, you get a room, and the board is meaning that not only do you get a room, but they're going to take care of you while you're in there, and that's what the board means. Then, of course, you're going to have a nurse attending you, and any other of the ancillary services that are involved. You've got the hospital, or and this again includes the critical access hospital facilities, and you're also going to have access to medical social services. A lot of people don't realize that medical social services is an aspect of the hospital, but it's a whole department in and of itself. And what this department does is it works really on a patient advocate access avenue, I guess you could say, as well as making sure that when you leave, you understand what care you need and follow up. If like a person's going to be discharged as an inpatient and they're going to need home health afterwards, or maybe they're going to need it's a new mama, first time baby, and that she had complications, and so she's going to not be able to take care of herself as well, but she's well enough to leave the hospital. What other kind of services are available to help with that, or even children that are going to need follow-up care, making sure that that all of those outside services are you're informed and aware, or helping you get them. So again, you'll have bed and board, and that means that they're going to feed you. You're going to have nursing and ancillary staff. You're going to have use of the hospital facilities, or even with the critical access hospital facilities if something goes wrong, as well as the medical social services. Now, in that umbrella, that means that you're going to have all the medication that you need. In fact, they don't really like you bringing in your medication, even if the doctor says, well, we're going to give you some ibuprofen. They don't want you dipping into your purse or your bag and pulling out ibuprofen. They don't want you taking anything that they're not aware of. And so if you choose to do that, you need to let them know ahead of time and say, I brought ibuprofen. Can I just take my own? Yes. And then the nurse would come in and watch you take it and say, yes, the patient took their own over-the-counter ibuprofens that they brought with them, et cetera, et cetera. All the supplies that you need, meaning while you're in-house, if you need dressing changes, catheter changes, things like that, that's all included. Appliances, any equipment that's needing. So in other words, when they check your vital signs, and they come and do that, all that stuff is supplied. Diagnostic and therapeutic services. So that means if they need to run tests to check your blood sugar, or they're checking lab results, or let's say you had your knee replaced and they need to start you on therapy right away in-house, and they're going to discharge you in 2 days, but they're going to start their therapy in-house. So they get you in there and they put your leg in the special wheel thing and you cycle it. Both medical or surgical services. So if you have to, they admit you with an acute appendicitis and they want to do an appendectomy. So of course, then they would be providing that in your inpatient services. Some hospitals are resident hospitals or training hospitals, so you have access to interns, and residents in training will also be there if it is a teaching hospital. As well as transportation. So they're talking about transportation in the facility, right? But they also are saying that, if you need transportation to the hospital, right? So ambulance services a lot of times are associated with a hospital. So how do these hospitals get paid? Well, they get reimbursed by IPPSs, and that's called an inpatient prospective payment system. And nobody wants to say that. So they use IPPS. We're going to see several of these abbreviations today. IPPS, just understand that it is for inpatients. It's a prospective payment system. So what they think they're going to get paid. They get Medicare IPPSs on a discharge basis, or Medicare. What they do is when they work with patients in inpatient states, they're very perspective, and they've really got it down to a science. They know what they need to do. They know what it's going to cost them to take care of a person that's getting a hip replacement or a knee replacement, or who has an emergency appendectomy, who has these particular procedures, who has a heart attack, who has a stroke. They almost know, it's a science, what they need to reimburse or what's going to be paid out in this hospital. Excuse me, my mouth's dry tonight, so I'll probably be taking a lot of drinks. So again, the Medicare IPPS, a lot of these hospitals, that's the backbone, of the reimbursement of the hospital. Not only does Medicare have this down to a science, the major hospitals, the big hospitals do too, because it's not cost effective for them not to know this. And that doesn't matter whether it's a private or a non-profit or a for-profit hospital. You have to do this, or you can't afford to run your hospital. Again, Medicare Medicare's inpatient is a prospective payment system. So they're thinking ahead what they expect to pay. They use Medicare based on how severe the diagnosis is, and they have an MSDRG methodology. So the MSDRGs, that's kind of the money of the hospitals. This is the science, the methodology of making sure what something costs is we're going to be reimbursed for that cost. So you never want a procedure like having a hip replacement. If we do X amount of hip replacements in a year, this is how much it costs us to perform his hip replacements. So therefore, how much is Medicare going to pay out and everything. Again, this is all done on diagnostic related group methodologies. That's what MSDRGs, they utilize that. So what is an MSDRG? Well, it's just a classification system. So it's saying, a hip replacement costs X amount of dollars. A knee replacement costs X amount of dollars. If we're going to do a heart transplant, it's X amount of dollars. And that's how they know. And so they group them up into a classification system, and it goes all the way down to, you know, orthopedic procedures, cardiac procedures, et cetera, et cetera. What happens when a person is placed on an inpatient stay? Okay, so there's kind of I guess you could call it a workflow of what happens, or let's say a timeline or sequence flow. So your patient is admitted into the facility, right? Then the clinician is going to document all of the services that are provided, right? There's lots and lots of paperwork, but everything, not just the services, but the diagnostic information is going to be all taken down and documented by the clinicians. That means that if you have lab tests done, if you have not diagnostic lab tests, procedures done, maybe you have a biopsy done, maybe they do an angioplasty, okay, all of that, as well as the medication that a patient's given, etc., that's all going to be tracked with the provider's orders, the physician's orders. Then charges are put into the system as they're doing that. Okay, so if the doctor prescribes a pain medication, let's say they're going to give you morphine every 4 hours for the first 24 hours for your knee replacement pain, then, you know, the doctor puts in the order for that. The clinician is going to document that that order has been received, acknowledged, and that the morphine has been ordered. And then they are going to actually document that they administered the medication and how they administered it, and any signs or symptoms or side effects of the morphine, or whether it was doing its job. That's all documented, and and everything that happens to that patient from the minute that they are admitted to the time that they are discharged, the clinician documents that. And then everything that they do will be charged out. So they used to have stickers on everything. So let's say that, you know, it's pretty common that you get one of those cups that they fill in with ice, right? You're charged for that. If you get the little puke cup thing, you're charged for that. If they give you the little pair of socks, the non-slip socks, they would pull off a sticker and they would charge you for that, right? If they bring you medication, they scan it or they pull off the sticker, they document it, and they charge you for that per pill. Okay, and the clinicians are in charge of that documentation and making sure that it's entered, so that you have an itemized list of everything that was done to you. That is also why an ibuprofen can cost you $5 a pill, you know, because of all of those steps that are involved in that. And then revenue codes that are assigned to that. If the medication, the morphine that was given to the patient for their knee replacement, those codes are matched with the charges, and then you get a charge master, which is kind of like an itemized list of everything that was charged to your account, and that is sent, that charging system is sent to the revenue center. Then after that, you know, now that you've got the money covered and the documentation covered, you're going to have HCPCS codes are assigned to the CDM. So anything that's non-surgical service supplies, and the HCPCS codes would be things like if you're discharged with a crutches or a cane, you know, those would be non-surgical services, right? So when they do an appendectomy, all of the equipment, it has value that they use, yet it is bundled in and packaged. So they're not charging you every time they use a forceps or the scissors or the, you know, they say the Metzenbaum scissors, this and this is, no. What they do is that stuff is packaged, sterilized and packaged together, and that kit you're charged for. So that's part of the procedure. that's included. The things that aren't included in that would be non-surgical services, like, again, those slippers that have the non-stick. If you at that little pink thing that you put all your stuff in, extra tissues being brought to your room, etc., etc. How do they uh, the HCPCS codes allow them to get reimbursed for the non-surgical. So how do they back up that a procedure was medically necessary, or your stay was medically necessary? It's done by the diagnostic codes, which is the ICD-10-CM codes. That is the code that tells you that it was medically necessary for you to be an inpatient. Thus, if you're going in to have an appendectomy, you've got to prove it was medically necessary. So the diagnosis would be acute appendicitis, right? And that would give them the medical necessity. Now, these are also based on CPT codes, and all of these, the CPT codes or revenue codes. Inpatient now uses ICD-10 PCS for the procedure codes. But if you're outpatient, not inpatient, they're going to be using HCPCS and CPT codes as well. And then that's all placed on UBO4 claim forms. And we've got a little picture of that coming up. What does the admitting office do? What's their role? Well, when a patient comes in to the facility, they're registered. And that's the first person that you're going to talk to. Even if you come into the ER, you're going to hit the admitting staff first. Could it be a clinician that's working that? Absolutely. It could be, because you may have one clinician, an RN, that is your triage nurse who's working admitting. Okay, so the admitting office, what they do is that would be, you're going to see them in your emergency rooms. Oh, that fly. Oh, we're going to have fun with that, aren't we? Ambulatory surgery centers, right? Hospitals, acute care centers, but they're either, or you'll be directly admitted by the provider. So that could happen where you go to your PCP, you're having chest pain, you think it's indigestion. Hey, come in, let's check you out. He says, no, something's wrong. They can even run a quick EKG, and they said, no, we're getting you to the hospital right away. So it would be a direct admit. So usually it's through the ER, the ambulatory centers and stuff like that. But again, it can be direct admit. Anytime that this patient is going to be admitted, what the admitting office is going to do is get the patient information first. Okay, and that is going to be will include insurance information. We need to know right away. It's very important to get the insurance information so that the facility can be reimbursed, right? There's protocols that each facility will have on how they do this, whether they do it first as soon as you come in, or they do it while you're being treated, or but they'll do it one way or the other before you leave. The demographics is also collected at this time, and that means, where do you live at, what's your address, phone number, things like that. What do you need to have done? Are you coming in for, a specific trauma? Are you coming in because of an illness or a pain? As well as the admitting office could be there for, I'm coming in to have a procedure done, and then I'll be here admitted and be here for 3 days. You always get the insurance card. That is a huge thing. Can't be overlooked. Not only do you need that insurance card copied every time, front and back, is because insurance changes and stuff. If you're missing even the middle initial and that's listed, then you're not going to get reimbursed from the insurance company. Everything has to be perfect or you won't get reimbursement, as well as your regular ID and verification that you are the person that's associated with that insurance. So of course they'll get a driver's license or an ID in some way. They set up an account for you. Everything's computerized now. And so, why they do that is because that you can transfer patient information from one facility to another. right? Even if you go in and you see your PCP and he says, no, we're going to admit you. I'm sure that you're having a cardiac issue. We need to get you in there and get a cardiac consult right away. Even if you go from the doctor's office to the facility, and even if it's not a doctor's office that is associated with that facility, it doesn't matter. Everything's computerized and electronic, so they can just whip that information over to you from one hospital or one provider to another. You can also, some of the smaller hospitals, they'll do patient's full medical records. They can transfer that stuff as well. The admitting office is also required to make sure you've given permission for consent to be treated. And this is just meaning that you're signing the form. When you sign your name, that it's written in there that says, yes, I agree to let you treat me. This only becomes problematic when you have children or underage patients and you haven't been able to notify their guardian or their parent. This can be an issue when you have kids visiting their grandparents. If a child falls and breaks his arm when he's on summer vacation with his grandparents out of state, the grandparent can't give permission for the child to be treated, and the doctor is not going to treat them until they get permission from the parent, unless it's life-threatening. And a broken arm isn't. Acute appendicitis is. But still, they work to get permission. So if you are traveling and you're traveling with children, or your children are going somewhere, it's always good to send a consent letter stating that, my mother, Mrs. Green, has permission to seek medical treatment for my child. And then you date it, et cetera, because of this, that you have to get consent when you're underage. The business office is a part of the HIM department, but they're also responsible for several things other than what we just talked about. Claims generation. They're the ones that are, the business office is going to make sure that the claims to the insurance companies are created. They also are going to send out those claims for reimbursement. They're going to take care of remittance documents. So whenever anything comes back, the incomplete or rejected claims, the business office is responsible for that, the billing office. So if something was put in that UB04 form incorrectly, or the insurance information was incorrect, the patient's birth date's incorrect, whatever reason, they're the ones that are responsible for taking care of that. They post the payments once they are made. So, Mrs. Green came in and had a left knee replacement, and it was sent to the insurance company. The insurance reimbursed, X amount of dollars, and that payment is posted. And so therefore it is put in the system that yes, the facility's been reimbursed for those procedures that have been done for Mrs. Green's account. And then you have appeals also saying, they rejected this particular request for reimbursement for whatever reason. Then they appeal it, and they're in charge of making those appeals. And there's other little reimbursement issues that come up from time to time. But if you're in the billing office, that's considered the business office, and the business office is the business office is the head window, and then the billing, HIM, and everything follows underneath that. And those are the items that they are responsible for maintaining. If you work in a small facility, you may be doing lots of these things. When I worked in the business office or in the billing office for a while at the hospital that I'd worked at for years, I worked for a specific amount of time in the billing office, and what they did with that particular office is they gave you a particular insurance that you were responsible. So everything that was Blue Cross Blue Shield that came in was this particular person's responsibility, and they did everything for that insurance for those patients. And then United Healthcare, Medicare, Medicaid, and like Medicare would be so big that you might have 2 agents on that. And then other places don't do that. They'll have somebody that does the claims, the remittance, and the filing, and then they have another one that does payments, postings, and that's all they do. And then they have appeals in another area. So and they cover all the insurances. It just depends how the office works. With the Health Information Management Department, which is HIM, you have to keep all of that patient information from everything that happened to them in the facility to all the charges and everything. That is all put in a medical record, and the HIM department is responsible for that. They will have a paper system that will be there in the facility so that, for quick checks and stuff like that. But now that the law requires all providers to use electronic documentation, it can be paper, but majority of this is all computerized. Okay, so when the physician wants to come in and look at the consult that the cardiac consult that was given by another provider, and he can bring it up and look, you can go in and look and see the charges that are brought up for that patient at that particular time. The provider can even go and, let's say they want to put them on a specific medication, but they need to know what insurance they're on because some insurances don't pay for certain medications. They can go in and look at that information as well because they need to know, and also this information is looked at immediate access. You still see the orders, the handwritten papers and orders and stuff like that, but a lot of hospitals have gone completely electronic, but not all of them are like that. I know that and I won't tell you how many years ago this was, but it was a long time ago now. But even when I worked in the ER, if the ER was particularly slow, they might send me up to the floor. And so I would assist a particular floor on, maybe it was just getting vital signs because they just had too many patients, or they had someone out and they just needed help with some simple stuff. So, everything was on a handheld device. And so you would literally chart everything in that little control box that they gave you. And you would, you had to put everything in manually. Now you can scan everything. But, and I would literally hand feed what the vital signs were for that patient, or anything that I had done for that patient. And any medication that was administered, et cetera, that's all done on that little handheld. And that was just starting, and it just started in the hospital when I was doing that. Everything before that had all been written by hand, and then you sat down and you charted everything in paper at the nurse's station. So you're not going to see as much paper now, and mostly computerized access, but it is for direct patient care. All this information is kept. So with the HIM, also you fall under the HIPAA privacy rule. Now, we are probably all very aware of HIPAA, but it has a dual effect. There's 2 things that you have to be aware of with HIPAA and the Health Information Management Department, the HIMs. One, it assures the protection of that particular patient's health information. It's protected. It cannot be given out to anybody that isn't directly related to their access or their care. And it also, the main reason that we have HIPAA, which a lot of people don't realize, it is for the continued flow of care for that patient, so that you can have the best care, the high quality, and the continuum of care. It's all electronic, and that continuum of care is going to be there. So that means that you don't have, I guess, too many cooks in the kitchen, they say? No, you have one primary care that has admitted you. You have a consultation and a team of providers and clinicians that are working for your care under one particular provider, and that if you're transferred out, that access, that information, everything goes with you, and so there's no interruption of care. That's a huge part of what HIPAA is. Yes, privacy is what everybody talks about and thinks about, and it's important because if you have a celebrity, or even not a celebrity, but say you have a celebrity come in to your facility, if somebody accesses that celebrity's information that isn't supposed to have access to it, then they can be fired, and they usually are fired because of privacy, right? But it's really overall the continuum of care, and there's no interruption of care. What about a critical access hospital, the CAHs? What do we do with the critical access? What is that? So Medicare conditions of participation follow under critical care. These are called COPs, and they are structured. They're different than acute care hospitals, okay? And that this critical access, they are for people that are more ill, I guess, than a regular hospital. What happens, these critical access hospitals are usually not in an area that you have access to the other hospitals. And they say at least 35 miles away from another hospital. Nowadays, 35 miles doesn't seem like much, right? But in other words, it's not easy to get access to another hospital. It is a smaller hospital, 25 beds or less, inpatient beds. And what they usually do is that they have a different length of stay than the acute hospitals. So no more than 96 hours of acute inpatient care. Okay, no more than 96 hours. How are these CAHs reimbursed? Well, it's cost-based. So if you need to know how they do that, they state that it's 101% of costs are received for, and I think that's funny, 101%. Inpatient, outpatient, laboratory therapy services, and post-acute care hospital swing beds, meaning this is a place where you stay when you're on the way to another facility. And so again, they have the inpatient, but they're small. Outpatient, they still do the lab and the therapies. That's how they're getting their reimbursement. They also do things like skilled nursing facilities. You can have a psychiatric unit where there's only 10 beds, rehabilitation units, and some home health agencies do this. But keep in mind this note, these are going to be services that are paid under a prospective payment methodology. Remember the MSDRGs, that all plays a part. These hospitals are reimbursed differently. Now let's talk about teaching hospitals. Teaching hospitals, there's several, and they're usually in a lot of ways sought after hospitals because they can be like an extension off a university hospital. The reason that they are wonderful is because they usually have the latest and the greatest techniques, right? You've got all of these great young minds working together. They also tend to be hospitals that are on the cusp of new treatments, as well as trying things that other hospitals may not have access to, as well as just having more manpower, because they don't just have interns, but they have residents as well. So again, what are teaching hospitals? They're hospitals that are associated with a medical school, and the medical schools are training physicians. All right. Now there's several there are medical schools that train clinicians that can be associated, but that's not the same. We're talking about a teaching hospital is a hospital that is associated with a medical school for providers, for physicians. They have to be approved by the GME for a residency program in medicine. And it can be a specialty like osteopathy, dentistry, podiatry, things like that. But all in all, even though you may be exposed and having these students, whatever year they're in, treating you and working with your plan of care, you still will have a teaching physician that is in charge of all the residents and the residents in a group. So if you have a cardiology specialist, there'll be a teaching physician that is has a cardiac residency or students under them. And they receive direct Medicare GME payments for resident services. Okay, so they're getting paid for the work that the residents are doing, but everything falls under the window of the teaching physician. They have document standards that you need to be aware of. That it is very important that you understand that that it still has everything has to be signed off by the teaching provider. Okay, so what you need to know is that for Part B, to get Part B payments for resident services, with or without a teaching physician. Okay, there are ways to get paid for that. Now, experimental and research projects, they don't get paid the same. These are initiated by the provider in the teaching hospital. Okay, so there's different ways for that to work, but all the documentation has to be clear as to what it's being associated with. Also, you have to have consistency, and you have to have a standard of care. Both of this has to be taken care of usually by the compliance department. Make sure that all of this is being reflected in a teaching hospital. There can, when you're dealing with a teaching hospital, it's kind of like it's a different ball game. And there are a few extra hoops that have to be jumped through and some extra paperwork that has to be done, but they got it down to a science. You just have to be aware of it when you're working with them. Well, what about graduate medical education? Again, teaching hospital, but this is on the graduate level. So you have the teaching physicians have to go to school for a minimum of 8 years, and then they can also specialize. But if you have a residency program, they're in graduate school, and so it has to have an accreditation, and this is for the Council for Graduate Medical Education of the American Medical Association. Okay, they have to have that. Other ones, there are other accrediting specialties. So if you're going to specialize in cardiology or oncology, again, there are special associations associated with them that the hospital has to have accreditation through. But they do take part in the GME residency program. And then again, this would be specialties like medicine, the osteopath, dentistry, and or podiatry, and there's many more. You have to be aware of the policies and the written documentation guidelines, because if they are unique, like I mentioned before, with teaching hospitals. And the salaries, the resident salaries and fringe benefits all play under this. And the teaching physician is compensated for the services. They are not payable on a fee schedule. The payments themselves are per resident basis and are hospital specific. So like Mayo is a teaching hospital, and we're in Missouri, so I'm thinking of University of Missouri, and I've been there and worked with them. So that comes to mind. They are a teaching hospital because they have a facility there. When we were in St. Louis, Washington State was there, and so they called it WashU, and then it was associated with Barnes and as well as Barnes Jewish and there's another one there, not St. Mary's, but there are other, but WashU is associated with them and given residence to them. So Medicare Part A payments still fall in the inpatient MSDRGs. That's all done the same. The additional payments that are made for the teaching facility, all is incurred with the MSDRGs. Specialty care hospitals. This is the one where it's a specific serious medical condition that the patient is being treated for. So let's say my aunt was in a car accident way back when I think I was a freshman in high school when that happened. And so she had major head trauma. So she went actually to the University of Missouri, and once she got out of ICU and was sufficiently recovered to where she could start her recovery stage, she was sent to a specialty care hospital, which was Rusk Rehab. And I think Rusk is named after somebody. But that's where you stay longer periods of time. It's something specific that she had to be treated for, a specific head injury. And they need intense specialty treatment. There is a 3-year moratorium on the establishment if you get a new TCH. Average stay is 20 to 30 days in these areas. And to define, how does CMS define an LTCH? It is actually, and this was a quote, a hospital which has an average inpatient stay of greater than 25 days. So this is not going to be your acute care hospital. They can't treat you. It's not cost effective, and they usually don't have the specialists there to treat you for that. So it's a specialty care facility. They are usually more severe. There's more complexity in their care, and the condition is serious. They get transferred from an ICU a lot of times to an acute care. Their level of care is at a different standard. It's not that it's better, it's a different standard. That means the clinicians and the providers have different specialties and training. The nurses have credentials in your specific needs, and they don't offer the range of services that an acute care facility would offer. It's a narrow focus. How are they reimbursed? Well, it's a long-term prospective payment system. The PPS payments for the LTCHs are given at discharge, and they use DRGs, which is a patient classification system. What about skilled nursing facilities? Now, skilled nursing facilities we've always called SNF, right, for SNFs, but there's more than one type of skilled nursing facility or SNF floor or SNF facility. And so this could, they may not all call them a SNF, but what happens with a skilled nursing facility or a SNF facility is that these are patients that need daily care. Okay, they need more care than what an acute care would give you, but they don't need specialty care like the specialty hospital. These are people that, would be needing rehabilitation services, or they have disability or illnesses that have them incapacitated. They stay longer periods of time, long-term in some cases, and they are much longer than acute inpatient stays. They are and can be hospital-based, and they can be freestanding facilities. So the hospital that I worked in the ER with, the SNF floor was an active floor, but it was usually a slow floor, right? So these people needed individual care, more things done for them, meaning, they probably couldn't get up to go to the bathroom. They weren't getting better soon. They were going to need intense supervision, but they would get better, if a SNF floor. So these are people that are not sick enough to stay in the acute care hospital, but they weren't well enough to go home yet. All right, so they put them on the SNF floor, knowing that they would be, they didn't need to go to a nursing home. They just needed to be able to stay somewhere with that individual care a little longer, but they didn't need the acute care that they got on the floor. They are also facilities that have your nurses, your clinicians, and therapists, but like everything else, they're under the direction of the physician. They could be things like keeping they've post-surgery and keeping the dressings clean because the people can't do it themselves, or they've had an infection. Tube feedings for a while. They've got to be on IVs for a while with medications. Maybe they need therapies before they can go home. Occupational therapy being a big one. If a physical and occupational, if a person has had a knee replacement or a hip replacement. And then of course you have speech therapies as well. A person's had a stroke. Right, think about that. CMS principle governing therapy services. Well, this is something you have to be aware of for SNFs as also. So if you have a patient that has a medical condition, and what you need to know, what the provider is trying to decide, do they need skilled therapy, or are they able to go home? Do we need to keep them in acute care? What is that dividing line? Well, you have to keep in mind that the diagnosis or the prognosis is not the deciding factor. It plays a part, but it's never the sole reason why you would have somebody in this facility. Also, the main thing that you have to know is that it's not the diagnosis and the prognosis, but it's that this facility has the skill set in this facility to treat this patient. So that's where you fall in with the therapies, or a particular illness or injury like a head injury and they're recovering, an amputation, things like that. So can they can't go to a place that has these non-skilled personnel. It's the fact that this facility has the skills set to treat the patient based on their diagnosis and prognosis together. So again, it is not just the fact that the patient had a head injury, it's the fact that they need skilled care that they can't get by outside non-skilled personnel. And of course, they have to be reimbursed as well. So SNFs are a prospective payment system. Again, they have a PPS. They use the RUG, or the Resource Utilization Group Payment Classification. That is different than the MSDRGs. They have a PPS, covers everything that's happening, all operating and capital costs in separate payments. And then you have that when everything is really high cost, those ancillary services, they're not going to be usually provided in a skilled nursing facility. Outpatient facility. What do we do with surgery centers, right? And you have a lot of those now. Surgery centers, these are ASCs that pop up. They can be also within a hospital. They're just a different department, or they can be independent. And you have a lot of these being privately owned. The independent ones, they do the outpatient prospective payment system, or the OPPS. But if they're not owned by a hospital facility, but is owned by a private, maybe a physician or a corporation that's not affiliated with the hospital, that's how you get the facility ones versus the independent ones. And they do pop up quite a bit, these surgery centers where, like they do an orthopedic surgery centers, and they do knees. That's all they do, is procedures on knees, and they've got it down to a science. Then with the independent ASCs as well, they can have Medicare and Medicaid services, but that are incorporated with the OPPSs. Also, Medicare does allow payment to the ASCs for surgical procedures, but they're under they're payable under the independent ASC benefits. Still going on with the independent ASCs, CMS covers the procedures as a list. They have a list of the approved procedures that they will do for these independent ambulatory centers. Otherwise, they want you to do them in-house. Then surgical procedures that are office-based have payment limits with surgery centers. So again, they're a list of what they can and cannot do to be reimbursed in that way. Medicare has a program for payment for independent ASCs. If you have a hospital-based ASC, then you could be in the building space that is, associated with the hospital, but it is part of the hospital. So it's got to be physically separated. It's got to be a different building that is being used. Now, again, these buildings can be very close to each other and stuff, but it has to be its own identity. Then it's billed and reimbursed as an outpatient department. Okay, so you can have the same billing and coding information, and you can still have the same people that do the billing and coding, but with the hospital ASCs as other hospital outpatient services. But ASCs are unique in that way that they have to be separated. Well, the facility is going to charge the cost is actually how they're going to do that. They're going to provide the cost that it is for like doing a knee at this ASC. Hospital-based ASC, maybe, that specialize in orthopedics. And so the charges and everything will be run through those. But the facility component is also incurred because you've got the nursing personnel, the room, and costs and stuff like that with the treatment, etc. And then your reimbursement is variable depending on geographic location. Okay, so meaning that reimbursement will be different in a large city compared to geographically a small city. Houston's going to be reimbursed more than like San Angelo was if they had an ASC. Now, continuing with the hospital and the independent ASCs, you have to be clear that the independent ones must be financially separate. They have, not only are they independent in what they do, they have to be independent from the hospital and their reimbursement. They are freestanding, a separate facility or freestanding. They have to have a separate tax identification number, the tax ID number for the ASC when it's independent. That means the claim submission, everything is got to be separate from the hospital cost report. And the physician services, you are not going to code and build by the facility unless, the only exception is if the physician is actually employed by the ASC, and that does happen. Not all the time, but you have to be aware of that. So if you're going to be doing the coding for an ASC, knowing the difference between a hospital ASC and an independent ASC and how the billing is done for each and what would constitute a difference, like being an employee. The clinical laboratory surgeries, pathology services and stuff like that, that's all done on a separate fee schedule, and they're paid differently with Medicare. Now, if you're going to do commercial insurance, then there's usually a standard of cost. So it costs X amount of dollars to do this procedure. Then there's contracts that are signed with a management agreement. You still have fee for service, and you have predetermined fee per visit procedures. That's all established ahead of time with these particular ASCs. When you do diagnostic testing, testing, when you're doing the outpatient diagnostic, I'm tripping over my tongue. When you're doing the outpatient diagnostic testing, the patient's responsibility is only to require that the diagnostic services are going to be performed by the physician's office, or not. Now, if it's not going to be done in the physician's office, they can go to an independent diagnostic center. That would be like the doctor isn't going to do blood draws. Their office isn't set up to do blood draws, so they're going to send you over to have an outside independent service do that for you. They may even have that independent office in their facility, but they're not doing it. They're separate. So when the patient comes in, they're going to have lab, radiology, all this stuff done. What's going to usually happen is that you have to be upfront and clear who is being reimbursed, why they're being reimbursed, and who's being billed, etc. This is going to mean that both with the attending physician and the written reports, that all has to be communicated in what's being done, who's doing it. And it's typical. This is standard. So with the therapy that goes along with outpatient, and this includes physical, your main ones, your physical, speech, and your PT, OT, ST. Well, these all can be done on outpatient departments, and you can do them on a regular basis. So the outpatient therapies, my son had gotten all 3 therapies, and they went to a rehab center, which was an outpatient therapy center that they were able to go on a regular basis to them, but the order still came in for these from the provider. And then again, you can have reoccurring accounts with the hospitals so that they can capture all the charges, and everything can be all kind of technically say that it's all on one page. If you're having chemotherapy or radiation therapy, cancer centers, this is also an outpatient facility, and there's a lot of these cancer centers out there. My mother used one that was Goldsmith Cancer Center, even though it was associated with a hospital, meaning a lot of the cancer providers referred and worked in conjunction with the cancer center. You had your own oncologist from and oncology interventional radiology oncologist there as well at that facility. They were hired by the cancer facility, and it was outpatient. And also it is how often you go to these different centers, repetitive, again, it would be repetitive services over a long period of time, is all dependent on the oncologist that's using the outpatient cancer center or working for the outpatient cancer center. So you would have a PCP, and then you would have an oncologist. They'd be working in conjunction, in that the oncologist would be taking care of everything that entailed your cancer treatment and communicating back to your PCP or any other physicians like your surgeon, as well as maybe the cardiologist or the urologist that they have you seeing, to make sure everything is going all right, because certain cancers will affect other organs, as well as the treatments can be hard on different organs. My mother, who had breast cancer, had treatment that her type of cancer was very hard on the heart, one of the drugs that she was taking in her chemotherapy. So she had to be seen by a cardiologist as well, because then they had to fine tune if there was a mitral valve complication that this one medication was known to cause. And she luckily didn't have that. So that was great. Also, besides cancer, you'll have dialysis clinics. Dialysis service is something that is deals with end-stage renal disease, ESRD, and so it is services that are going to be provided, like the therapies, where you're going to be going continually, and with dialysis, that could go on longer. That could go on for years, versus like the cancer, which could be treatment for a year, and then, if you went in remission and stuff, dialysis could go on for years until either you you passed or you got a transplant, or they were able to do, really the only cure for end-stage renal disease would be a transplant. So how are they reimbursed specifically under Medicare regulations? ESRD, you don't have to be 65 or older to get Medicare. You can get Medicare for end-stage renal disease to pay for that. So how does that correspond with what we've talked about to the ER? The ER is actually a hospital-based facility, but it's kind of it's an outpatient facility as well. So it's in-house. You can have ER departments that are off facility, but usually they're in facility so that they can be transferred inpatient. They are people that need immediate care. To be an emergency department, you have to be open 24 hours a day. They charge differently for diagnostic testing, and therapeutic services can be run through the ER, but it's charged differently. And so you can have a therapeutic service, but it would be charged as an ER encounter. Now they call them ED encounters. We always call them ERs. So emergency department, emergency room, but the professional charges are billed separately. So you will get an ER charge from the facility, and then you will if you could get an ER charge from the provider, the physician as well. And services that are provided could be charged separately. Now, that's different than a freestanding emergent care or an urgent care center. These do not usually treat people for things like heart attacks, strokes, life-threatening illnesses. If somebody comes in to an urgent care center or an emergent care with something that's life-threatening, they are definitely going to get you to the hospital-based ER so that they can get you inpatient right away. That's not what urgent cares are used for. Non-high complexity services, so minor procedures, they aren't set up. They usually have a radiology, small radiology department, but it may be the same clinician that is your nurse. It also takes the x-ray. The doctor may even take the x-ray. You never know. And then sometimes they have somebody that's there that takes x-rays all day. Minor procedures, things like sicknesses that you can't get into your PCP about, but but are sick enough that you need care over the weekend or in the evening when your PCP is not open or you can't get into. And also, they don't cost as much as an ER. I mean, it used to be that just to walk in through an ER was $100 charge practically. Now it's like $500. But also another difference between an urgent care center and a hospital-based ER is that they don't have to be open 24 hours a day. They do usually stay open longer, and it's usually things like 8 to 8, like a 12-hour day, or even 8 to 10, depending on how long they want to stay open, but they're not required to stay open 24 hours a day. That's not typical with urgent cares. Now we're going to talk about the coding in that. What is the coding for each one of these? What code sets are we going to be using? So for the inpatient facility, you're going to be using ICD-10-CM, as well as for the procedures that are done in-house, ICD-10 PCS. ICD-10 PCS, if you've been around for a while, in coding, that replaced volume 3 of ICD-9. All right, so it is a procedural code set that is used inpatient facility and replaced volume 3. You do not use CPT in inpatient facility. You can in outpatient. Outpatient facilities, you're going to use still your diagnosis ICD-10-CM. That's, straight across the board. That's what you'll always be using. But for the procedures, you won't be using PCS. You'll be using CPT and HCPCS level 2 codes. The HCPCS level 2 codes are, again, another code set for medication and ancillary supplies that are used, but CPT codes for their procedures in outpatient. Professional fee coding will be, again, the ICD-10-CM. You're going to use that with every single one, but instead of the PCS, you're going to be using, again, CPT and HCPCS level 2 codes. And that is what's going to wrap us up. I'm going to look real quick to see if we had any basic questions. It looks like we don't. We have the downloads and everything for you. Don't forget that you can go into the CCO Club and have your questions answered, as well as checking on YouTube and Facebook. Don't forget to subscribe to those if you want to be able to watch additional videos and get extra help on questions that come in. So please do that, like and subscribe, and check in with Podio and the CCO Club to have questions answered. I don't see any other questions, so I think that's it for us. Thank you very much for joining me tonight for this look at inpatient and facilities.